So good morning, everyone. We'll be moving on to the next topic here, which is the differential diagnosis of central serous carcinopathy. I have no disclosures. So by no means I will go over all the differentials that you can think of for in central serous carcinopathy, and I will just pick up some highlights. And if you want to learn more about this, I would advise you to read this paper by Camille. So when we look at central serous, like Camille just pointed out, the things we look for are the presence of subretinal fluid and abnormal choroid or choroidal changes, and some certain specific on FA and ICGA. But when you think of the differential, you should look for other signs on the OCT, certain retinal changes, maybe even symptoms or a patient's history that may guide you actually to the correct diagnosis. And this is of course important because the correct diagnosis gives you direction to how to treat, or maybe not treat, just wait and see, and it may actually save a life. So this is the differential diagnosis, the list I will go over quickly. So this is the first case, a 23-year-old healthy male who just happened to come in because of his family history of glaucoma, and the resident saw this subretinal fluid, and the patient was referred because of the central serous carcinopathy. And indeed, there is subretinal fluid there, and maybe some changes in the choroid, but if you look at the fundus, so we usually do multimodal imaging in central serous carcinopathy. I'm not sure that in this case this was really necessary, because if you look at the fundus, you can already see what the diagnosis is, and this is a torpedomaculopathy. So this is congenital. Moving on to developmental differential diagnosis of central serous. This is a 9-year-old girl who was actually treated for alternating occlusion therapy because of amblyopia, and she was a high myope, as you can see. So at one point, there was someone who thought, sometimes we occlude the right eye, then the left eye. What's going on here? Let's make an OCT. And this is when they found subretinal fluid at this point in the right eye. So here's the FA. Not much going on here. And the answer was actually in the vertical OCT. And this is a dome-shaped macula. So this 25-year-old healthy male came in to the emergency room because of loss of vision in the left eye. And he was also referred to me because of his central serous carcinopathy. And indeed, there is presence of subretinal fluid, some focal thickening, possibly of the choroid. And here are actually the OCTs of his right eye. And look here. You can see that this entire segment is kind of pushed upwards. And this is how his left eye looked when he came to see me. So it was like perfect. But do you see the changes of this possibly focal change in the choroid in the image just above? So I asked him, it's like, did you have any other symptoms at the time? He said, yeah, I had a lot of pain in my eye, and I had to use ibuprofen to get through the day. And this is posterior scleritis. This 51-year-old male I'd seen in 2012 because of central serous carcinopathy in the left eye, and he was treated with photodynamic therapy, and it dried up nicely. And then he came back. He said, I have the same symptoms. My central serous carcinopathy is back. I want you to treat me with PDT again. And this is what we saw. So there's the FA and the ICG. I made a green almost circle around it. This is like a plaque that we see on the ICG. And the interesting thing is when you look closely at the OCT, yes, there are choroidal changes. Well, he had a history of central serous carcinopathy, but this is what the real problem is at this point. So you see splitting of the Bruch's membrane and RPE, and with these peaked kind of changes. And this is a type 1 macular neovascularization secondary to central serous carcinopathy. So this pachychoroid-related neovasculopathy that Camille already pointed out, it's usually type 1 neovascularization with or without aneurysms. Of course, these patients have an abnormal choroid because that's part of the disease. They're usually younger, there's absence of drusen, and especially these peaked changes that these peaked PEDs that we see in the OCT give the diagnosis away. The next case is a 29-year-old healthy male who had been followed by one of my colleagues because of this central serous choroiditis, and yes, there is subretinal fluid, and yes, there is an abnormal choroid. But I think it's very different from the other images that we saw in central serous choroiditis. And here's the FA, and yes, there may be a smokestack here, but this is what we saw in the ICGA, and there is a washout in the late phase. And this is a choroidal hemangioma. The next case is a 77-year-old male, which is already rather old, I think, for central serous. It's not impossible, though, but it makes you kind of suspicious, like, is this really what is going on? His vision was also pretty poor, and this actually, so there's subretinal fluid. The choroid we couldn't really see on these older OCTs. And this was one OCT after PDT and one after anti-VEGF, and it looks like the PDT really worked, but this was in a time where we didn't really have the follow-ups with the OCT, so this was just taken at a different position. So there was actually no response to either PDT or anti-VEGF. And this is what his fellow eye looked like. And then I ordered the FAF when I first saw this guy. And I just finished my residency. He's one of the first patients that I saw. And I wanted to stop the injections, and he was really reluctant to do so because he was told, if we're going to stop the injections, you're going to go blind. And then I looked at the FAF, and you see it's really symmetrical. You know, both eyes, OCT, fundus image, and the FAF. It's so symmetrical that I asked the patient, said, you know, I think this may be something genetic going on. And then the patient said, doctor, could it be Best disease? I was like, oh, that's a brilliant idea. And then he said, yeah, well, you know, both my mom and my son have Best disease. So there you go. So moving on to systemic diseases that go actually with central serous choroidopathy, or images that look like that. Camille already pointed out Cushing disease, Cushing syndrome. This is a patient that was also referred because of central serous choroidopathy. This is her fellow eye, but look at her fundi and the fundus autofluorescence. You see the peau d'orange there and the angioid streaks. So this is pseudoxanthoma elasticum. These patients need to be referred to a center that has experience with pseudoxanthoma elasticum, and you may actually, you know, make such a big difference in these patients' lives. You can actually save a patient by giving this diagnosis, although it's, of course, not a nice diagnosis to get. This is a patient that is from Elon van Dijk's thesis, a 64-year-old male. Okay, there's subretinal fluid there. Choroid may be a bit abnormal. You see these intraretinal changes as well that we sometimes see with very chronic cases, but somehow the shape of the subretinal fluid doesn't really look like a very chronic case. And this is a slab of the OCT a bit lower, and there's like confluent areas of subretinal fluid here. And this patient had a metastatic cutaneous melanoma and was treated for this with a MEK inhibitor. And personally, I've never seen a case, but this is reversible, so you don't have to take them off the medication, right? Yeah. So the final case I want to show you is a 27-year-old female. She was actually admitted to the neurology department for sudden onset of nausea and vomiting. She had paresthesia in her hand and her face. She had pain in her belly and acute drop of visual acuity in the left eye. So she was referred to us. I was a resident at the time, and we could only make these OCTs. She was too sick for any other imaging or exams. So yes, there's subretinal fluid, choroid may be abnormal, and then we just sat down with my boss at the time. So we're looking at a very sick patient. There's acute central serous carcinopathy. There's hypertension. She had elevated liver enzymes, thrombocytopenia, pain in epigastrium, and nausea and vomiting. So we thought, could this actually be HELP syndrome? So this is what we reported back to the neurology department. They did some additional imaging, which is maybe not the first thing I would do to figure out if a woman is pregnant, but I'm just an ophthalmologist, so what do I know? And indeed, she was pregnant. She didn't know it at the time. Labor was induced. She gave birth to a healthy baby girl, and this was a couple of weeks after we saw her. So she dried up nicely after giving birth. So the differential diagnosis of central serous has a long list. Look for presence of subretinal fluid, the abnormal changes you expect in the cord, and if this is not the case, do multifocal or multimodal imaging and go over this list to try to figure out what's going on. And remember that a correct diagnosis of central serous carcinopathy can actually save a life or two. Thank you very much for your attention.